Bismillahirrahmanirrahim. It's always a pleasure to talk in cardiology updates. So I will be very brief about, because the detailed guidelines is being discussed by Dr. Abid. So important thing is that we have to differentiate between hypertensive, emergency and urgency. Combinedly it's called a hypertensive crisis. So let's start with the scenario. A 56 years old male who is a school teacher presents to the hospital with severe headache and mild chest pain. He denies any severity and association with food or change in posture. He walks a mile brisk every day. He uses combination pill therapy daily for his hypertension, which is well controlled but have missed from last few days. His blood pressure at the ER is 220 by 110 and has no significant findings on examination. What next best management plan about him will you do? So anyone from the audience? Option A is giving sublingual nitrates like Angicet to immediately lower the blood pressures. Option B is giving sublingual caputin captopril to immediately reduce the blood pressure. Option C is giving IV furosemide Lasix to reduce the blood pressures. Option D is reinstate oral previous medication. And option E is giving IV nitrates to reduce blood pressures. G. Option D. So the answer is reinstate oral previous medication. Why? We will discuss it. So anyone who presents with blood pressure more than 180 systolic and 120 diastolic, you have to look for the target organ damage, either new, either progressive, either worsening. So if there is any target organ damage, or the ISH guidelines call it hypertension mediated organ damage. So if there is any damage, it is called hypertensive emergency. And every hypertensive emergency should be admitted in ICU for three main reasons: for monitoring of the blood pressures, for quantification of the target organ damage, and for IV drugs. And then you look for some compelling indications like aortic dissections, severe preeclampsia or eclampsia, peuchromocytoma crisis. If any one of these three compelling indications is there, then you have to reduce the systolic blood pressure to less than 140 millimeter Hg during the first 1 hour. And if it is aortic dissection, the target will be less than 120 millimeter Hg. So these three compelling indication is important that you have to diagnose in every hypertensive emergency patient. If none of them is there, then you have to reduce the blood pressure up to maximum 25% in the first hour, and then 160 to 100 in the next 2 to 6 hours, and gradually to the normal within 24 to 48 hours. So if there is no target organ damage, either new, worsening or progressive, we called it hypertensive urgency. Only the markedly elevated blood pressure. In such condition, you have to reinstitute, you have to intensify oral antihypertensive drugs therapy, and you have to follow such patient. The second scenario, a 60 years old male is brought to the ER with sudden loss of power on the left side of his body, with the angle of mouth deviated to the right for the last 2 hours. His daughter states that it was sudden with no fits or loss of consciousness. He uses Valsartan 80 mg, amlodipine 5 mg for hypertension, glucopage for diabetes, and aspirin 75 mg daily. On exam, blood pressure is 200 by 100, pulse is 80 per minute, power on left side is 1 by 5 with Creener 7 palsy and a left upgoing planters. CT brain rules out hemorrhage. You decided to give thrombolytic therapy because the patient is well in time. So how would you manage his blood pressure in ER? So option A is give IV nitrates to immediately lower his blood pressure to 140/90. Option B is give IV labetalol to immediately lower his blood pressure less than 185 systolic and 110 diastolic. Option C, give his own oral medications. Option D is don't give any antihypertensive medication for 72 hours. And option E is lower his blood pressure to less than 185, 110 after thrombolysis. So option B is the right answer. So managing hypertension with acute stroke, according to the guidelines, if it is acute ischemic stroke and the blood pressure is elevated, acute means less than 72 hours, then you have to look either your patient qualifies for IV thrombolytic therapy or not. If the patient qualifies for IV thrombolytic therapy, then you have to reduce the blood pressure less than 185 and diastolic blood pressure less than 110 with before starting initiation of IV thrombolytics, and then you have to maintain the blood pressure less than 180, 105 for first 24 hours or after IV thrombolytics. If the patient didn't qualify for thrombolytics, then you have to look for the blood pressure value. If it is more than 220, 110, then you have to reduce the blood pressure 15%, but it is class 2B recommendation. If the blood pressure is less than 220, 110 and it is acute ischemic stroke and the patient is not fit for thrombolytics, then initiating or reinitiating antihypertensive therapy within 48 to 72 hours have no benefit. It's class 3. And for pre-existing hypertension, reinitiate antihypertensive drugs after neurological stability is class 2A recommendations. Management of hypertension in patient with acute intracerebral hemorrhage. It's a bit different from the ischemic stroke. In acute condition, less than 6 hours from symptom onset, spontaneous intracerebral hemorrhage, then you have to look for the BP value. If it is more than 220 millimeter Hg, then you have to lower the blood pressure with continuous IV infusion and with close BP monitoring is class 2A recommendations. If the blood pressure is between 150 and 220, then it's rather lowering the blood pressure, it's harm rather than benefiting the patient. This is one of the slide in patient when you stabilize the ischemic patient and after 72 hours how you treat it. So if the patient is previously diagnosed, then you have to restart antihypertensive treatment is class 1 recommendation, and as Dr. Abid mentioned, the aim is almost in all guidelines 130 and 80. And if the patient have no established hypertension, you have to establish the hypertension. If it is more than 140/90, you have to start antihypertensive medications. But if the blood pressure is below 140/90, then the usefulness of antihypertensive medication is less established. These are some of the drugs you must know in your serious and emergency condition, that which IV medication can be used in your patient. So in all conditions like malignant hypertension and CAP, acute ischemic stroke, in acute ischemic stroke with thrombolytic indications and acute hemorrhagic stroke, the first line treatment in guidelines is labetalol, if not contraindicated. Contraindication is second and third degree heart block, some airway diseases, and if you don't have labetalol, then you can use nicardipine in such conditions as an alternative. And sodium nitroprusside is the alternative strategy. But in acute coronary syndrome and acute cardiogenic pulmonary edema, the first choice is nitroglycerin and labetalol is the second choice. In aortic disease like aortic dissection, which needs aggressive blood pressure monitoring, the first choice is esmolol and nitroprusside or nitroglycerin Labetalol and metoprolol are the second choice. In eclampsia and severe preeclampsia, labetalol again is the drug of choice, is IV, and you have to give magnesium sulfate to such patient as well. Thank you.